Is Claudia Minas, and today I'll be discussing pericarditis for my pathophysiology course at St. Petersburg College. Pericarditis is the inflammation of the pericardium, the thin protective sac surrounding the heart. In this presentation, I'll define the condition, describe its impact on the U.S. population, review common causes and risk factors, explain the underlying pathophysiology, outline clinical signs and complications, discuss treatment approaches, and highlight nursing evidence-based practices for patient care. In the U.S., recurrent pericarditis occurs in about 11 cases per 100,000 people, with roughly 37,000 individuals living with the condition. Nearly 40% of patients experience repeated flare-ups. Hospitalization is frequent, and complications such as effusions, tamponades, and constrictive pericarditis are common. The financial burden is subsequential, with inpatient care accounting for over half of the total costs. Causes may be infectious, such as viral or bacterial origins, or non-infectious, including autoimmune disorders, renal failure, cancer, or certain medications. Risk factors include being a younger male, having a prior cardiac injury, living with autoimmune or connective tissue disease, being immunosuppressed, or having chronic kidney disease. Inflammation of the pericardial layers increases vascular permeability, leading to fluid accumulation within the sac, known as effusion. Rapid fluid buildup can restrict the heart filling and cause a tamponade. Chronic or recurrent inflammation may result in fibrosis and scarring, progressing to constrictive pericarditis. Recurrences are often linked to an exaggerated immune response, particularly involving interleukin-1. Typical symptoms include a sharp and sudden chest pain that worsens with inspiration or lying flat and improves when leaning forward. A pericardial friction rub is a hallmark finding. Other signs include difficult swallowing, fever, fatigue, and restlessness. Possible complications are pericardial effusion, cardiac tamponades, and constrictive pericarditis. First-line treatments involve NSAIDs and colchicine to control inflammation and reduce recurrences. If ineffective, corticosteroids or interleukin-1 inhibitors may be used. Severe cases may require procedures such as pericardiocentesis for tamponade or pericardiectomy for constrictive pericarditis. Nursing care emphasizes vigilant assessment and monitoring of chest pain, vital signs, and ECG changes. Interventions include keeping the patient upright, administering prescribed medications like NSAIDs and colchicine, and promoting rest. Patient education is critical, teaching recognition of early symptoms, adherence to medications, and lifestyle adjustments. Nurses also play a vital role in team-based care and preparing patients for urgent interventions if complications occur. Here are the references for this presentation, which includes Stat Pearls, the Journal of American Heart Association, and the Textbook of Understanding Pathophysiology. Thank you.